Hello, you all. My name is Margo Hutchison. I am a family practice doctor by training and have been on the board of the Yaya Foundation for about 2 years. Got involved with the Yaya Foundation actually through watching Ron and June from pregnancy on to the birth of their daughter, Yaya, and just going through the whole process of discovering that she had 4-H leukodystrophy and through all the medical procedures and things that they did, and then eventually her passing. So that's my background. I'm here today to sort of facilitate a talk about 4-H leukodystrophy. I'm going to see if anyone wants to go over the sort of the nuts and bolts of the disease or not after we introduce each other. And then if they don't, then we will go on into sort of just questions about once your child is diagnosed, practical pieces, finding doctors, advocating for your child, insurance, things like that. So what I'd like to do is have maybe Valerie introduce yourself, then Elsa, then Tammy, and then Georgia, and I believe it's Stacy. So let's just go around.
Yeah. Sorry, and I should have introduced you guys.
That's what we're doing now.
I'm Valerie. I think most of you know me. I'm the research director for the Yaya Foundation for the last 6 years. That's it.
Okay, I'm Elsa Keeler. I am a retired primary care pediatrician. I practiced for about over 25 years and then had to retire quickly due to an illness, and got involved with the Yaya Foundation because I'm friends with Margo. In my practice, I was in a suburban practice in the Twin Cities metro area, and many of my patients had complex or special health needs. So I spent a good part of my career coordinating care with pediatric neurologists, endocrinologists, and other subspecialists using a medical home model. So I'm here as a listener and maybe to give a little bit of a pediatrician's perspective.
Yes, excellent.
Tammy? Hi, Tammy Bach. I think most of you already know me. Mom to Julia, who's now 24, serve as a community liaison for the Yaya Foundation, and here I always learn something and to help answer any questions.
Awesome. Thank you. Georgia?
Hi, I'm Georgia. I'm from the UK. I have one child. His name is Miles. He's 7, and he has Polar 3B.
Okay. And just tell us one thing.
Saying hello.
Okay. When was he diagnosed?
He was 3.
He was 3. And tell us something special about Miles.
Miles is very loving. He has a gigantic smile and he's very affectionate.
Oh, I love that. And then Stacy.
Hi, my name's Stacy. My son Connor has Polar B3 and an undiagnosed cyst, and he's 15.
Okay. How old was he when he was diagnosed, Stacy?
7.5.
7.5. Okay. And tell us something special about him.
He's very caring.
Oh, I love that. And where are you located?
Pennsylvania.
Pennsylvania. Good deal. Well, thanks for coming on. Both of you, our expectation is there are about 20 people who signed up for it, and many people will actually be listening to the YouTube, and since it's during the middle of the day. So what I'm expecting is a round robin discussion.
Margo, we have one more.
Oh, okay, super.
Lynn, do you want to introduce yourself?
I'm Lynn Moss. I'm a grandmother to Adele who has 4-H. She was diagnosed when she was about 1.5 years, and she's now 11 years old.
Wow. Tell us something special about Adele.
She has a great sense of humor.
Oh, I love that.
So
that's great.
And a great memory and full of ideas.
Oh, Love that. That's great. So the first question, and I'm going to ask all of you this, if this is supposed to be an intro 101, which is going over the nuts and bolts of the disease. What is leukodystrophy? What is white matter? What is myelin? And how does it present? Now, if you watched last week, Friday, Genevieve Bernard, the physician, she did a very good job of that. So I was hesitant to redo that. I also know a lot of you are fairly fluent in the basics of Polar 3. So the 4 parents, can you just tell what you would prefer? Maybe start with Tammy and then go to Stacy. Georgia.
A high-level overview is always helpful, just to kind of get a point of conversation going.
Okay. Lynn, Stacy, Georgia, do you echo that?
Yes.
Yes.
Okay. All right. Then that's where we'll start. I'm going to refer you, and you may not have it yet, but if you're on the Facebook page on January 11th, as they were sort of advertising this class, they talked about a link. So if you go back to the Facebook page, you will find a link, and it is called the Polar 3 / leukodystrophy guide by the Yaya Foundation. And this is a 4-page document that was put together by 3 of the people on this call. It's an overview, genetic causes, clinical problems, different things that your child can have, and then resources and medical management. And I would think if there's anything you take away from this class, it's to just pull that off. This overview can use with family, with your friends, with doctors, teachers. People get curious. Church. What is this 4-H leukodystrophy or Polar 3? So that's one piece of information that we'll be going over. So basically, as an overview, 4-H leukodystrophy or Polar 3, it's called both leukodystrophy right now. The 4-H was an older term because of how the disease presented. The Polar 3, then the Polar 3B, and all of the different genetic changes are because now we're doing genetic testing and we know where the mutations are at. The leukodystrophy, as you all know, and I think leuko means white, dystrophy means dysfunction of. So it's a dysfunction or problem in the white matter, in the brain, the spinal cord, and the nerves. As you all know, the nerves are the parts of the body that moves information from the brain down to the body, be it for movement, or anything. And it's like an electric cord. The myelin comes from a cell that coats that nerve so that the messages can travel appropriately and at the right speed. And unfortunately, that's where these leukodystrophies are a problem, is that there have been mutations and changes in the manufacturing of this myelin that causes children and then some adults to have low amount of myelin. So hypo means low, so hypomyelin, low myelin. The body is not making enough. There's another type called myelin homeostasis. It's just when the myelin doesn't work well. So you can see how both of those would matter, and how it affects your child it depends on what the defect is. If some of you are on the call last week, Dr. Bernard did a very good job on this recent paper of looking at all the genetic mutations and then showing what sort of problems show up. And to me, as a physician, I thought that's pretty cool, because one of the issues with a leukodystrophy and with Polar 3 is that we can't tell you exactly how it's going to show up, how severe it's going to be, how it's going to progress, and even what symptoms you're going to have. And often it's a wait and see, though often it does progress. And I'm just thinking now that this paper is out that parents will get a little bit more of a roadmap. Even the way you guys are presenting yourself. When we first started working with Ron and June, it was 4-H leukodystrophy. Now it's like, well, my child has a polar 3B. You're already using the genetic terms, and we'll be able to know more about it. When it shows up just depends on how severe the myelin loss or effect is. It can be early childhood, as early as really 3 weeks. I wouldn't say 3 weeks. I'd say probably 2 months would be the earliest you'd start being wondering. That's how it was with Yaya. And for those of you who don't know, Yaya was the child who had 4H leukodystrophy of Ron and June Garber. I think Lynn said her granddaughter was diagnosed at 1. Stacy, Stacy, you said your son, whose name is
Connor.
Connor was at 7.5, and Miles was at age 3. And then when was Julia diagnosed?
About 12 years old.
12 years. So whatever, meaning that the symptoms were so different at literally from age 1 to age 12, that it took that long, that some of those cases are milder. Maybe Julia, I'm assuming, is milder because it took her longer to be diagnosed. And then the different symptoms that you can get, the ones that are most important and that diagnose children with polar 3 related leukodystrophy are the neurologic symptoms. So those can be many different things, from having tremors to having spasticness, difficulty walking, large motor problems, small motor problems, holding things, balance, coordination. That's what is the largest segment. The other issues are things like small stature. That is because of hormone-related issues that can also show up with polar 3. They can have difficulties with speech. They can have difficulties with feeding. Teeth, hypodontia. That is, the 4-H comes from 4 different words that have H in it that are some of the symptoms. And the teeth can just come in funny, not at all, later in life, abnormal shape. Children can have learning problems. They can also have visual abnormalities. So anywhere that's a nerve is innervated and there is a need for myelin that's not working properly, children can have symptoms. The genetics, most of you may know, but it's what's called an autosomal recessive. And recessive means that each parent has genetic input into a child. So 23 from a mother, 23 chromosomes from the father. And recessive means that each parent carries that gene, but that gene's not going to get expressed unless there's 2, one from the mom and one from the dad. That becomes important for other children, because if your child does have polar 3 related leukodystrophy, you may have children who are unaffected but are carriers. And that becomes an issue with, genetic testing. My guess is, I feel like we've talked about this before, that I don't know if those children show any expression of it or of the disease or not. I'm wondering about that. So we'll have Valerie, do you know? Carriers?
I was just uploading stuff. Was the question whether carriers have symptoms?
Well, do carriers ever seem to have symptoms at all? I'm sure it'd be very mild. And
we don't know.
Okay.
The short answer is we don't know. There is currently no indication that there are symptoms in carriers, but as you said, they might be very subtle.
Mm-hmm.
And certainly not like disease-like. So we frankly don't know.
Okay. And so that makes me think that in general, if there are, it would be very mild or basically not at all. That the other gene is carrying strong. The other gene, basically an autosomal recessive, means that the non-affected gene is very strong and is masking the gene that is a carrier.
And I think we can safely say that is true in the vast majority of cases.
Yeah. So let's just, I was curious, and the reality, the answer to my question is no. They do not show symptoms. That other gene is the strong gene and masks the carrier gene. Right now, I believe we know of 5 polar genetic mutations. One is on polar 3, and then it's A, B, C, and D sites. And then there's a polar 1C. Is there anything I'm missing?
No.
Okay. Okay. And then really we get into from there just what do you do now? You know, you've been through this diagnostic dilemma with what does my child have? You've gotten genetic testing, and now you found out. I'd like to hear from the three, four families that are here. How did you find a primary care doctor, and has that been satisfactory? And do you have any tips? Let's start with Tammy.
Sure. So because Julia's 24, the symptoms of the 4-H were still kind of being cobbled together. So Julia's initial diagnosis was cerebral palsy, and the biggest symptom she had was ataxia. So we saw a neurologist who was ataxia based. That was his specialty. Then once we were officially diagnosed, it was from Dr. Wolf and Dr. Vandernap in the Netherlands. And they are the ones that then recommended Dr. Vandiver when she was in DC. And so as far as a neurologist, then she worked with our ataxia specialist here in Chicago, just to kind of share records and talk about, the prognosis and what does this all mean, again, because it was so new. So they just kind of did a cooperation, if you will.
Okay. Georgia?
She's, I think she just stepped away for a moment.
Okay. All right, Stacy?
Well, with Connor, he was always falling, so his pediatrician referred us to a neurologist down where we live, but they found it was like going back and forth. So I pulled all our records from there, and now we're at CHOP. So we see Dr. Waldman every 6 months.
Okay. And Lynn, do you know about Adele, what her care is?
What her symptoms are, you mean?
Well, did she work much with a primary care doctor, or is she mainly working with a neurology specialist?
Mostly with a primary care and actually with a kidney specialist, because she had some seizures with high blood pressure. We live in a very small town in Colorado, so
okay.
The hospital, Denver hospital with the specialist, is a 3.5-hour drive.
Okay.
So it's basically with her primary pediatrician.
Yeah, and I think that's a very representative from someone who's very close to, expert care, to you and your family being farther away. Elsa, do you want to talk about the work of a primary care doctor and what they can do for you?
Sure. Yeah, Lynn, I empathize. I think that there is such a difference when you're 20 minutes away, a drive through rush hour, maybe, but still, from subspecialty care, and 3 hours away. And sometimes then the primary care clinician, the pediatric family medicine or nurse practitioner, can become more involved then and help coordinate. And I'm hoping also the specialty centers can oftentimes coordinate, so you can see both the neurologist and the kidney specialist, within a day or on the same day. But yeah, that's it can be challenging, and likewise, when you're really connected. So I think Tammy, your experience is a little different, and when you're really connected to a specialist, oftentimes that person is the person that you rely on for a lot of the care, and it may be the neurologist that ends up saying, "Oh, we're noticing this. Let me refer you to another subspecialist." So oftentimes the referral doesn't come from the primary care doctor. It might come from the neurology specialist to the endocrinologist or to the gastroenterologist.
I'm going to do a segue there. A letter was put together, which really could probably be used for any neurology, but it's a letter explaining 4-H leukodystrophy to a primary care provider. And that is on the January 12th Facebook post. It's called the Physician's Letter that you can print. Another thing to note is that it is also on the Yaya Foundation website under newly diagnosed. If you pull down that tab, you'll find, if you don't have Facebook, you can pull it down there.
I put it in the chat.
Oh, thank you.
You can download it from the chat.
Yeah, maybe Elsa, explain that ICD-10 code and how important that can be to a physician.
Sure. So probably about between 10 and 15 years ago, there was a law passed that we, as a nation, we're going to transition to electronic medical records. And it's a concept of portability, meaning if I go to a different state or different town, or within the same town to a different clinic, I would be able to have access to medical records. And this has been, while it can get really complicated, it's been an amazing thing for families, especially when your child has, multiple medical concerns. And in that medical record, most typically, whatever version, there's a lot of communities use Epic, but there are other versions of the medical record when you go to see your primary care or your specialist. Right in the front of the chart, this electronic chart, there's oftentimes something called a problem list or a diagnosis list. And this is an easy way to open up your child's chart and see at the very beginning, these are the major health concerns that my child has. And the way that they're put in there is with something called an ICD code. And these are universal codes. So they're recognized. Oh my, are they recognized all over the world? I think.
Good question.
In many countries, as far as I know, I'm not entirely sure whether they always have exactly the same meaning, but in general, the hope is to generalize it across the world.
I thought so, and some countries have adopted additional codes that we might not have adopted yet in the United States. So there is a code. There is a code for POLR3 related leukodystrophy, and it happens to be G11.5. This, while I think as a primary care physician, I may not immediately know that code.
No, you wouldn't.
This letter, and I am holding a copy of the letter in front of me. And it's also on the website. I know.
I just put it in the chat.
Yeah, it's in the chat and it's on the website. You can download it. That's where I got this one. But this letter or summary is a really nice way for families to communicate, I think, with primary care. As a primary care pediatrician, I mean, honestly, before 2 years ago, I knew leukodystrophy. I knew the much more common types of leukodystrophy, but I had never heard of POLR3. So, and I think naming is strength. So for me to know that this is the diagnosis my patient had, and to be able to put that in the front of her chart would, I think, just be very helpful for family and for long-term care management. So.
And I think it also helps with billing on the physician side, that rather than, you just put some, this lets them know this child has a complex disease. This will take longer. The doctor will then get paid for a little bit more time, which is what every patient and family wants, is time with their doctor. So it is a very important thing. And this document has resources for doctors on it, and it also has resources for patients. And Tammy can speak to it, and Ron could too, and many of you that once you got diagnosed, you didn't have many resources. But boy, if you have this letter, the doctor will be able to go to town with it, as will your family and you. So I think getting into the leukodystrophy centers, has anyone had much trouble finding one or finding a specialist? Tammy, you want to start with that? And then we can go Georgia, Stacy, and Lynn.
I have a new person, Kathy, on.
Okay. Hi, Kathy.
Hello.
Hey, Kath.
Hi.
So again, because it was so new, we had Dr. Vandiver at Children's in Washington, D.C., which kind of was my first introduction to a group of parents and doctors that were studying 4-H.
Mm-hmm.
And then we just followed her to CHOP. So
Okay.
I kind of got right in on the ground floor.
Okay.
I didn't have to do a lot of research.
So there was no Googling or, okay, good.
No.
How about you, Georgia? In the UK may be different.
I've been to see Professor Wolf once.
Okay.
I would really like to go back, but I'm finding contacting her very difficult. She doesn't have a secretary, and of course she's very busy. So to get a response can take quite a few months.
Oh, that's hard.
Yeah.
Yeah. In the US, usually the leukodystrophy centers have what are called care coordinators, and because you're right, trying to get to the physician can be like, this is not going to happen, or they get so many calls. But I wish that she did have an easier way to get to her for you, because that's a long time to wait.
Yeah, we don't have a leukodystrophy center in the UK that I'm aware of.
Okay. Stacy? Did you find it hard to find a leukodystrophy center and get in?
Well, we were when we went to CHOP, that's when we got his diagnosis.
Okay.
So it was very, like, when I got the phone call for the appointment, she's like, it could be this or couldn't be this, and then I Googled and then I cried for an hour. So
yeah, that's understandable.
It was hard, but going there now it's great.
Good.
To CHOP, so
good. And with you being in Pennsylvania, I mean, that's the place to be. That's great. And
it's
then,
only a 2-hour drive.
Yeah. And Lynn, with Adele, again, you have a drive. Were you able to get into the leukodystrophy center in Denver easily?
No, we were not. There's a wait. We went to a leuko conference in Omaha, and we did see Dr. Bernard there, and she had a visit with Addie and explained things to us. And then I think it was 2 years later, we did go to Montreal to see Dr. Bernard.
Okay. All right. Kathy, what has been your experience working with a leukodystrophy or neurology specialist? How hard has it been to get in?
Once we got the diagnosis, it hasn't been hard to get in. It took us 15 years of going to all these other, Mayo Clinic, NIH, Mount Sinai, just you name it. We did all of it. And we couldn't find what was wrong. And then finally, Erin saw the Yaya Foundation on Facebook, and she explained that. So we went to that conference. We went to that conference. We saw Dr. Bernard, and then we went to CHOP. And so then we got the rough diagnosis. But Erin is 38.
Wow.
And so I noticed things when she was starting to walk.
Oh,
but everybody just thought something was wrong with me. You're not really seeing what you think, and she's going to grow out of it. and, you know, have her wear skates that'll straighten her legs up. I mean, just on and on. And so it's just been very difficult. Just and I'm the diagnosis is tough because we don't know what's going to happen. But you can we were able to get into CHOP, so that was really good, and able to talk to Dr. Bernard. So I think that once you get there, you're I mean, I'm saying to the moms, you're okay because they're going to get you in. Okay. But you just gotta be persistent, and you gotta be persistent, and you know, if it takes emailing and writing, I know, just keep doing it because you got to get your child seen.
You do. I think Kathy's point, I mean, even as a physician recently, I was dealing with a medical problem and they gave me an appointment 4 months out, and then I called a different, you know, and you keep bugging them. You have to be, you know, patients would tell me like, oh, well, they haven't called me yet. And inside I'm saying, honey, don't expect anyone to call. I mean, this is my bias as a physician. Don't expect them to call you. Things fall through the cracks. Messages don't get read. You are the advocate. You make the phone calls. You probably won't talk to the doctor, but if you can get a hold of care coordinators, ask to talk to their nurse, ask to be put on wait lists, ask for Zoom calls. All of you, I think we're up to 5 people now, have shown that you were persistent. I mean, Kathy, from age 1, not knowing, and you just kept going. I mean, you know, and trying to figure this out. I mean, I think all of our collective hearts go out to you.
Thank you. And I, you know, and I know everybody else is the same. You notice things, especially as a mother. You notice things before other people really see it. You know, they're in denial most of the time, and you're just like, no, there's something that's not right. And we got the same thing. It's cerebral palsy. That was one of our friends who he's passed now, but was a surgeon, and he said it was cerebral palsy. We went to University of Alabama. They said cerebral palsy. So about 3 diagnoses with cerebral palsy.
Yeah. Well, as Dr. Elsa Keeler, who's also on this call, said, you know, we would never have heard of it. I mean, I have literally gotten abnormalities on x-rays as a primary care doctor and Googled the abnormality, and then it comes up as this syndrome. And you're like, I don't know what this is. Right. You know what I'm saying? I mean, your doctors are like you all. If it's not common, they're not going to know much. So you are the expert on this disease. I mean, obviously there's experts who are experts too, but just realize that all these misdiagnoses are happen because it's rare. What have all of your experiences with insurance been? Has insurance been a nightmare? Are there any like tips you would give each other or other people who will be listening to this later about dealing with insurance companies?
I can tell you I've been on both sides of being insured, like through a real insurance company that you pay, and also through the state because of Julia's bio dad. Anyway, and I can tell you that I was of the assumption that like a Medicaid, you could go into any basically big hospital and be covered. And I found the hard way that doesn't work. And so even with Medicaid, like University of Chicago isn't covered. Lurie's is, but only for certain things. Lurie's Children's here in Chicago. So trying to verify coverage from a Medicaid side is just as hard or harder, and trying to find physicians that are in network with Medicare, Medicaid are very difficult. And on the other side with insurance, because it's so rare, it's like they hadn't heard of it. And so what is this? And so doctors would just get creative, and like for endocrinology, they wouldn't even use 4-H. It was just like, well, we're just going to check bone age, not for any reason, but we were doing it because of 4-H and because of growth hormone issues, but just coding it as though she was a child, they were just going to check bone age. So learning to like not even involve the real diagnosis with some of the specialists.
Yeah.
Just coding it different.
Yeah, that's a tip right there. Let's go Georgia, again, different situation in UK. Maybe she's off. Stacy, Lynn, Kathy, what has been your experience with insurance? Any tip you would give people?
Well, Connor has state insurance, so I haven't really had any major issues. So if I get a referral, it's the only thing is when I have a hard time renewing it because I have to send so much documents to the state to like verify it so he can stay on it. So that's the only thing I really get annoyed with. But he has a caseworker through his insurance, so we like talk every 6 months and they have no issues. So I know everyone's different, but I feel like that's one stress I don't have to worry about.
Okay. Glenn, do you know if insurance has been an issue, or if you have any tips that the parents have?
I know my daughter-in-law spends many, many hours filling out forms. And they spend the summer in Wisconsin, near an hour from Chicago, and she would love to take her to the specialist in Chicago, but the insurance will not cover it.
Yeah,
that's horrible.
It sort of is what it is, and that's hard. You hit a roadblock. Yeah. Kathy?
For Erin, like I said, she was diagnosed later, like in her 30s, and she was already working for the government. So she has insurance that covers everything and that covers things. So, and also she is able to work remotely from home, even when everybody else had to go back to work for the government. She has, I forgot what they call it, but it is, I can't think of the term right offhand, but she's able to work from home. And so she just had to go through the process of getting that paperwork approved so she could work remotely.
Yeah.
Then they came in and made sure like her desk and everything was, the right height and all of that.
Good. That's great to hear that she can be employed and that they have accommodated her. That's wonderful. Another issue that's come up is different specialists other than your leukodystrophy center specialist that you need to see. Tammy, you were going to talk about ophthalmology and why you recommend that.
Right. So vision with the myopia is very, very common. And
explain myopia.
It's short-sightedness. So seeing distance is very difficult. Up close is a lot easier, but myopia can also become problems with the optic nerves. And with the optic nerve, it can do something called pallor, Pallor, which is a thinning of the optic nerve. And that can subsequently lead to a detached retina. And that can detach at any point. So I think it's really good to school yourself on symptoms of detached retinas so that your child can indicate to you if they're having some symptoms. The neuro-ophthalmologist in Julia's case, we took her a couple of years ago because I was noticing that even though she has glasses and she had the correct prescription, she was tilting her head when she was reading. When she went to read, she would like read sideways. And what we discovered is her field of vision in one eye is narrowing. And her peripheral vision is off on one side more than the other. So the neuro-ophthalmologist can go and do a lot of different tests that you're not going to get at a regular eye doctor. He's definitely a step above an optometrist and a step above a regular ophthalmologist because he's neurological, so he understands more than the brain aspects of what's going on with the vision. And so we were there for about 2 hours.
Wow.
He gave us a wealth of information. And the health of the eye is just really, really important. And I think sometimes, at least I did with Julia, okay, she's got glasses, she can see, on to the next thing. And what I didn't realize was that, they're not going to pick up the health of the eye or the vision in a regular, regular visit to Target. So for us, it was a good idea to go back, get another baseline. And now instead of going to just an optometrist, we're going to go start seeing an ophthalmologist. Not a neuro, but an ophthalmologist now for regular eye exams, so they can continue to check the health of the eye. Unfortunately, there's not much they can do, but at least they can keep track of what is going on and just relay the symptoms and just kind of be more knowledgeable about the health of their vision.
I personally think, and I guess Valerie, I take this to you, that what is how should every family with a child with polar 3 related leukodystrophy see an ophthalmologist, just for a check? I don't know the answer to that. I think that's something we could get to, like Dr. Bernard, and just have her answer.
I think that Dr. Bernard or Dr. Vanderveer would be better people to answer that. But it certainly seems to be something that affects many and is worthwhile keeping an eye on. I mean, I also sometimes hear parents say, and all of you on the call know that better, but there are so many appointments. Which one should I go to? That's perhaps something that you or Elsa can chime in, but how do you select that? But
well, you want to do that one, Elsa?
Yeah. What I would say is that when you have a genetic-based condition where it is a known fact that myopia is common, what we would typically recommend is probably around age 3. I'm going to go out on a limb here, but in other genetic conditions that children are obviously born with, that are associated with different eye conditions, either farsightedness or nearsightedness, age 3 is a really good age. Before then, if things are suspected, but age 3, and there are pediatric ophthalmologists, and I would just echo what Tammy said. I think if you have access to a pediatric ophthalmologist, I would ask for that, and I think it's based on this medical concern, even though in a sense we are screening if you don't have concerns, but that's what I would recommend as optimal care, if you will.
Do you want to explain because the ophthalmologist versus optometry, do you want to just give a quick, make sure you get the MDDO version of that in this case?
So optometrist is definitely skilled in screening for medical diagnoses. So for instance, Tammy, you did very excellent description of the progression to detached retina. So an optometrist needs to be able to screen for all of that, but also spends the majority of their time figuring out whether someone is nearsighted, can see near and not far, or farsighted, or can screen for glaucoma. But the ophthalmologist is the one who manages the medical conditions that progress. So when you have such a high risk of something that could progress. It makes sense that you would want to follow with an ophthalmologist.
Yep. So that's they're going to either be an MD or a DO.
Correct.
So you'll look for those initials at the back of the doctor's name, or ask in the clinic before you set up. We have about 10 minutes. Do we want to?
Can I say something really quick?
Oh, sure.
For Aaron's, she had, I guess, for a lack of words, we call it a lazy eye, only in one eye. And so we would take her to all these eye doctors, and they would do all these exercises we had to do, and they did patching on one eye to strengthen the other eye. And then they wanted her to wear contacts when she was about 5 in one eye. And so our neighbor would come over, because he was an eye doctor, and put the contact in every morning. And then we stopped that. And then when she got ready, she puts it in the one eye, the lazy eye. And it's just, we don't really know, where to go. Because she has the, one eye is okay and one eye is not. So that's also, I don't know how, she just wears a contact in the one eye now.
Okay.
So.
Well, and again, is that associated with the polar 3?
Yes.
Okay.
Yes.
So that's just, another problem other than the myopia and the retinal detachment.
Right.
Is the lazy eye. The couple topics that have come up are things like the endocrine issues, hormone replacement therapy. Tammy, do you want to give a summary as a parent, what, just of what your thoughts are, or what are the different thoughts are? Maybe if any of your children done hormone replacement therapy?
No.
No. So obviously part of the 2 H's, which is why we were letting it in Julia diagnosed, was she was too young to have started puberty. And so the question comes up still in our private Facebook group is, do I start puberty hormonally with my child or do I not? Initially, I'd say 5 or 6, 7 years ago, the doctors were kind of mute on that, and they would say to the families, that's your decision. Now there's more of an understanding of a couple things. First, if they go through puberty naturally, there's obviously nothing you can do about it. But going through puberty obviously makes their bodies bigger. You've got more hormones, you've got more functioning of the body, therefore more things for the brain to process and take care of. So it's just more work for the brain that is not myelinated properly to do. So that's going to decrease functioning somewhere. Secondly, you would have to be on that hormone therapy for the rest of your life. Most importantly, there was a study done about 2 or 3 years ago where Dr. Wolf and others ran a study on the effects of hormone replacement therapy. And even with our kids with polar 3 that were given full treatments, it was not as successful. I think the success rate was about 30%. And of course, you have different issues with male, female. You have female with menstruation, and then if you choose to do hormones to stop that, that's one side. With males, then you have, their bodily functions and erections, and what do you do with that? And so it opens up a whole wide avenue of what do I do? One of the things that I was told early on, it made sense to me, was, does Julia sense it? And do you think she needs it for her own well-being? Does she need to, be given hormones so she can feel more like her peers? And she never has. And there are certainly things parents can do to help enhance that without hormones. So it is still a parent's decision. it's a decision that is obviously not taken lightly, but there's a lot more information out there now than there used to be. And so on our private Facebook page, there in the form section, the document is in there on the study they did. So I think now Dr. Vanderver for sure will say no to hormone replacement. Before she was kind of neutral on it. But again, there's a lot more information than there used to be.
Okay. Yeah, thank you for the summary. In the interest of time, I think we will just have that be our summary on that. So thank you very much. One question that comes up, and maybe Elsa, you could deal with this. MRIs are confusing. Do they really help? Do they not help? Can you sort of give a parent the advice you would give to them about where they're useful, where they're not useful, and what we can learn from them?
Sure, and I think someone Georgia had mentioned that that Miles had an MRI around age 2, and around age 2 is where you would expect to see a good amount of myelin formation, and prior to that, an MRI can be very helpful in terms of recognizing, the structure. Are things in the places that they should be? What does the child's, brain and spinal cord look like? Are there tumors? Are there things there that shouldn't be there? But in terms of like prognosis, in terms of saying, what's the extent of this disease, it's not going to be very helpful prior to age 2, and even beyond age 2. So an MRI, it is as useful as it is. They're highly sensitive. There are sometimes findings that we don't know of the significance. So I'm not aware of any standard of care for MRI to be done at certain ages. We might get there in the future. I think as the tool itself becomes more specialized. So I'm curious about other people's experience with that. If you're told that your child should have MRI every so often, or if that's something you're interested in.
I can speak also as a physician. I feel like we have sold the fact that MRIs will tell you exactly what's going on and what problem and what to do next. And I spent much of my career telling people what in my field, which was more spine medicine, was we would look at the MRI, we'd shove it aside and say, now tell me how you're doing, and how the patient is doing, how your child is doing, what was going to determine what we do, much more than an MRI. And I think people feel like, I want an MRI, I want to know what we can do and we can fix it. And it's an MRI. I think Elsa said it beautifully. You're looking for other things to rule out. Yaya, who did pass away at 13 months, as you can imagine, guess what? Her original MRIs were all normal. Well, we know that's because she wasn't myelinated yet. So I think, like you said, it can be helpful, but it will not change a lot of how they treat your child. But your doctor may want it every so often, and maybe every so often you feel you want it, and that's just a discussion to have. Any of you have questions about that or other thoughts? Elsa, you might say differently.
I would just say that if there's a sudden change,
that's a good point.
You are seeing, or your child, adolescent, or a young adult is saying, I feel different. I think sudden changes are certainly indications for repeating lab work, repeating imaging. Absolutely, because you're looking. You've got a sudden concern, and you're looking for an answer.
Yeah, that is an excellent point, and that's true in almost all of medicine. If something has changed, let's try to figure out why. It could be MRIs, it could be labs. That's another question that had come up is, for non-affected siblings, when or do you do genetic counseling? Do we have, it is exactly 1:00. Is it better to continue with that question? That's really one of the last ones, unless people have questions. Valerie, I'll leave it to you. Should we stop at this?
Well, let's ask, does anybody have questions that you would like to put to
Yeah.
Margo and Elsa or Tammy and me? And otherwise I can talk a little bit about genetic testing.
Okay. Georgia, did you come on for a specific question that we haven't answered that you'd like to bring up?
No, I have no questions. I've just committed myself to attending each and every conference.
Thank you. Thank you for that.
No problem.
Stacy, any specific questions that have been missed or that you have curiosity about?
I always have questions, but right now, none. The only thing is my son sleeps more than I feel like he should be sleeping, but that's my only question.
Okay. That's something, again, that's a change or something that's abnormal, then it's something to talk to your provider about. It can be medication side effects. It can, but yeah, definitely worth looking into that. Lynn, any questions about Adele? That you
She
want to
has
answer?
something called intermittent vomiting. And I know I see Elsa, you're shaking your head. It lasts about one day, and then the next day she's fine.
Yeah.
Symptoms are yawning and all of a sudden tired, and then she's sick to her stomach.
I empathize with you. Yeah, sometimes historically we'd call it cyclic vomiting, and you might just have a couple of clues that it's going to happen, and it can be very difficult, difficult to treat, difficult to prevent. Yeah,
that's hard. Kathy, any questions that you wanted to bring up or share?
You talked about the MRI. Is there going to be like a comparison to other, like just other kids or people with the diagnosis that can compare why their symptoms are different? Will that show in an MRI? Or, like I'm worried, like how do we know, other than Erin, she went from walking to now she's to a cane to a rollator. So none of that will show in an MRI, like the progression.
Well, that's an excellent point. And I don't know if you're aware at all, Valerie, about that, but your question is, have they compared MRIs of polar 3 related leukodystrophies and symptoms?
Right.
And then if she is in essence, deteriorating, not doing as well with her ambulation, is that something that if we saw the MRI, it would give us some help?
Yes.
So I think that would be a question we'll send to, the leukodystrophy specialist, Dr. Bernard Vandermeer, and then Dr. Wolf, and see if we can get back to you all about that.
Yeah. And vaguely, I would say is that there are certain things where between the different subgroups of 4-H leukodystrophy, like the striatal form or the what we call classical form or the spastic ataxia form, I think there are differences that can be diagnostic, but not 100%. And I'm not sure how much they can say about prognosis, which Kathy is what we all think are mostly worried about is what's going to happen. Once again, I'm not I'm not a clinical person, but from what I read in the literature, mostly not. But I think we should ask Dr. Bernard about that.
Okay. So we will get back.
I would take it with a grain of salt. Yeah.
Yeah, and I think we have all your emails, so if we can, we'll get you to get that question to her and then get back.
Well, you want to speak? Dr. Vanderveer or something.
Yeah. Any of the, do you want to speak to the genetic counseling with siblings?
Yeah, I just wanted to talk about genetic counseling for siblings. Somewhere that question came up, and because all siblings have a chance of healthy siblings to be carriers for 4-H leukodystrophy of one of the mutations. I think it is important that siblings have genetic counseling. And the question is mostly when. And when should they be tested for carrier status? Now, because we think that mostly if you're a carrier, you won't have any symptoms. So it is not important for their own health at this point. But it becomes important when we reach reproductive age and when we can have children of our own, that we know our carrier status for these disorders, so that if you decide to have children, then you can have your partner tested and see, and then you have still options before you become pregnant. So this is really what I think, this is the problem about it, and or the space we are in. And for instance, I think it is good to talk to them about the time, whenever the time is, that your children ask questions about this. It depends on your child. Some children are very curious, some are not. But perhaps around adolescence, it's a good thing to talk about and give them the option, to get tested, or at least the knowledge that they should get tested before they consider having children. So that's my. Has anybody questions about that?
Or Elsa, any caveat?
Yeah.
No, I think I just want to empower you as families. I think you know your family best, and um, and siblings of children who have special health needs are amazing people in and of themselves. So they have had to be stronger and wiser, probably at earlier ages, and maybe can handle information about that risk even more so than other people. Other families may differ, may say, no, that's not information I want them to know for a while. So I think it is a personal decision. I would say that there's a concept of personal autonomy and assent. Teenagers have the ability to make their own health care decisions, and once they do, then it's really important that they have this information. So for some teenagers, that might not be till they're 18, but for some teenagers, it might be when they're 14. So
Because the reality is there's at least if Mendelian genetics is true, there's about a 50% chance that they are carriers. Now the chance that they will marry or date and have babies or get pregnant with someone else who's a carrier, obviously
not that
it's
high.
not that high, but here we all are, and it happens. So yeah, so that's good. Well, from here, we'll certainly wind it up unless someone has any further questions or thoughts.
I have one. So Erin has a younger sister. She's 3 years and 3 days younger, and she hasn't shown any signs of 4-H. However, I think she has a lot of guilt. Erin, she walked differently throughout her school years. And Jordan was the one who, when kids made fun of Erin, that she had to step in and say, "That's my sister, don't you, and take up for her." So I think if there are older siblings or younger siblings close in age, they need, I think they need some kind of counseling and some kind of help. Because they're dealing with a lot of guilt, and they're dealing with it in their own different ways, just like we're dealing with it in our own ways.
You are absolutely right, Kathy.
Yeah.
And I was thinking of a personal example of siblings being strong and saying, oh, they're so strong. But it does not mean that they don't need support for themselves as individuals.
Right.
Yeah.
And I think the counseling is very important. They don't even realize how much they're carrying, how much she was carrying, literally defending her sister.
Yes.
And then sometimes what happens is they go through it, and then years later they need to actually revisit and come to terms with how hard that was.
Yeah.
So I feel like both of you are saying is give your child permission to just assume this is hard. And as a parent, it's hard, so that a counselor or a therapist can be helpful for everybody.
Yeah. And speaking of the siblings, I'm just trying to find the exact date, but we do have a seminar about unaffected siblings upcoming, Kathy. Because, thank you, Kelly. February 12th.
Okay.
Because we know how hard it is. And we know that siblings and others need support.
It'd be interesting.
And you as caregivers.
Will that be for the siblings? I mean, you expect siblings who are older, like Aaron's sister, to show up? Or do we expect that to be parents? I'm just curious.
Whoever wants to come.
Yeah, because she could talk about it maybe if she's up for it, her sister, Jordan.
Yeah, I think she will be up for talking about it. And I think it would be helpful for people to hear what she has to say, but it also would be helpful for her to understand what she's going through, because she's never really expressed it to us that in a certain way, but we know that she's struggling. We know.
Yeah, no, I think that would, and you had such a long time of not having even a diagnosis. And I think that probably made it harder too.
Yes. Yeah.
Kathy, that would be a blessing if she would be able to talk about it again, given her age and her experience, because we have a lot of families with, I mean, young children to adolescent to out of college, with unaffected siblings, and they all handle it in their own unique ways.
Right.
And I think it's really would be helpful to know that they're not alone, and their way of handling it is okay.
Yes.
Depending on what they need. But if she could speak to that, I think that would just be a really nice blessing.
Okay. And it's February the 12th. Yeah, I'll make sure she gets on the call. February 12th, right?
Yes, thank you.
I also wanted to mention one of our volunteers is Marian Callista, and she's a genetic counseling student, and she also has spoken many times to me that she's very interested in helping siblings because she sees that in her work. So perhaps if if you wanted to, I can make the connection between the two.
Okay.
Just to mention that there is a resource.
Well, and a sibling support group could also be another interesting thing for the right ages.
Yes.
Yeah.
Well, thank you to everyone. I sure learned things and appreciated hearing everything you all had to say. So, Valerie, you want to close us down?
I think too, this was a great session. Thank you for Margo, Elsa, and Tommy to talk about it, and thank you for everybody. for coming, for asking questions, for participating, for sharing your experiences. And it looks like we already have some marching orders here with the siblings groups. That is always good to know. And Keely, I think we'll put up the video in a couple of days, so that if you want to revisit something or want to send it to somebody who had to miss today, I know it's in the middle of the day for many of you. So thank you, and I'll see you next week.
Sounds
Thanks,
great.
Valerie.
Thank you so much.
Thank you all.
Thank you.
Thank you.
Thank you.
Bye.
Tammy, can you stay on
Thank
for
you.